We, in our practice, we commonly screen for the TB, so tuberculosis, and usually we don't want to, for that to be there. And also liver enzymes that need to be screened. And it's also approved for relapse remitting forms of MS. Oh, the third one, yes, the third oral therapy is Gilenya, which was, that was the first one that came out in the market, and that's, I think it's over 3 years now, and it is made by Novartis. This medication, in relationship to efficacy, we do think that it probably sometimes is probably as good as natalizumab. Now, this is, clinical observation, some reports. It is also for relapsing forms of MS. It is a medication that not only it's once a day, but there's a pre-screening. Several things need to be in check, and one is having had chickenpox, and so we usually check the varicella titer. It's also, we want to educate about potentials for inflammation of the eye or macular edema. We usually also require looking at the white cell count. It can drop dramatically. And other screening that sometimes we do need to do if there's other issues such as a cardiac history where a consultation with cardiology needs to be done. This is a medication that does require that the first dose need to be done in an observation area where we take a look at the heart rate because this medication can lower the heart rate and lead to arrhythmias or blocks in the heart, but in terms of efficacy, it's proven itself.
Why we should take Aubagio versus BG12?
Why? So, there is obviously the differences from once a day versus twice a day, but if one is, considering Aubagio or somebody is given Aubagio as opposed to BG12, it may be as simply as, based on the dosing, or maybe there is some liver enzyme problems that need to be considered. Because that was...
For which, so as a patient that has some liver problems to start with, shouldn't be on which one?
So if they have liver problems, that I would not put them on Aubagio, because Aubagio will increase the liver enzymes. It's actually one of the things that is looked at every month for the first 6 months. Tecfidera doesn't necessarily have an impact on liver, but I would probably watch it for both medications, actually for all 3 oral therapies. Which one? No, Copaxone is an injectable, along with the interferons, which would be beta-serin, Extavia, Rebif, and then the intramuscular one, Avonex.
There was a study, though, but
It didn't work out.
Right.
Yeah.
It was a very, very expensive protein meal.
So I have a couple of questions on to continue on the hormones and MS. These 2 questions are about menopause and before, so approaching menopause. And the questions are whether there's any change in disease progression with changes in hormonal cycles. And the answer is basically we don't know. Some people actually at Harvard are studying this. Somebody who's studying with Dr. Shitnis is looking into this. This is a very difficult question to answer, actually. The things we know are that the hormones of pregnancy, most notably estriol, which is one of the main hormones of pregnancy, actually seems to be protective against exacerbations and possibly maybe some progression of cognitive changes, but in terms of the changes that are seen around menopause, it's much more difficult to measure that. Maybe Tanja, you want to add something?
Yeah, so basically we have been very interested in this question. It's a very important one as women are aging. We want to know the answer, and several of the observations that we've made so far, one of the observations suggests that the type of menopause, how it's induced, might have an effect. So whether you might have taken an MS medicine which actually stopped periods like Novantrone or even cyclophosphamide. So chemotherapy-induced menopause is slightly different than what's called natural menopause, just going through that transition. Sometimes surgical menopause, some people might have their ovaries taken out for certain reasons, and that we're studying to see if that might have different effects. In other conditions, surgical menopause might have a different effect as opposed to natural menopause. So basically in about 3 months, we'll have more answers to all of these questions. And we're also looking at the effects of HRT, or hormone replacement therapy, what types might be both safe and might, if there is an effect of menopause and MS, mitigate that effect or change that effect.
That was part of my question, and I kept wanting to ask it every time I come to these symposiums, because the first time I ever had any problem with, when I got diagnosed with MS, was when my progesterone was just going, and I've always been really good hormonally, and I used to go like a powerhouse, and then all of a sudden at 45, I started to feel this, funkiness and whatever, and it was also the time when the recession was hitting hard, so the stress, and that brought me in for my first time that I had an acute, and the progesterone was starting to go low. And everybody knows, we've been told that women, when you're pregnant, their progesterone is so high, they never have any problems. So that's going to be a lot of women's question. Does the hormones play anything? Because, and the HRT, are they going to feel better and maybe not have any relapses? So you guys
Right.
are studying that.
Yeah, absolutely.
Yeah,
It's a
there
very
is
important question
a
to
national trial,
address.
which is sponsored by the National MS Society and the NIH, which has got, I get your part of that as well, the estriol trial, which will be ending in January. I happen to be the chairman of the committee that's looking at the safety of that trial. But there are 18 centers, and I think we will have a lot more information about the estriol component of this. But I have a prejudice, and that is, this is a disease that's more prominent in women. I think that one cannot ignore the hormonal issues in that situation.
Yeah, I think just one thing to add is that it's important to sort out the issues of just general aging as opposed to the hormone change, and that's an important factor that we're controlling for and trying to address in these studies too. Because MS does often change as anyone ages, men or women. Yes, there has been several studies now looking at the effects or possible effects of birth control pills on whether it could be a risk factor for MS. I think it's basically somewhat split. Most of the studies suggest that they're not a risk factor. I think there might be some other studies that have looked at it in different ways. Emmanuel, I don't know if you think there's a consensus on that question. I think right now we don't think that it's a major risk factor, but of course any hormones, could play a role, and also their interactions with any of the other risk factors might be important too.
I have 2 questions here that are not necessarily hormonal, both related to respiration and respiratory. One of them relates to exercise, feeling dizzy after 5 or 10 minutes, and the question, her lungs have been tested, or his lungs, I don't know if it's a male or female, and is this possibly an MS symptom? And I think that it depends on where the disease is. Clearly, we do see MS patients that have respiratory difficulties. The diaphragm's controlled by the neck, neurons and so forth, which means that if you have cervical spine disease, you could have some trouble with your diaphragm. And quite clearly, it depends on where the lesions are. The exercise issue, we like people to exercise 6 days a week. And if 2.5 miles per hour makes them short of breath after 5 to 10 minutes, I think they should go slower. And I think that maybe they shouldn't go 10 minutes, go 5 minutes. But the idea is that as you do this, you will build up positivity. There is good evidence that exercise is good for lots of things. It's good for repair of your nervous system. It's good for your immune system. And you also look better.
And so the breathing thing, I just wanted to add that there is a medication, Gilenya, that has been associated actually with a slight decrease in the breathing function. And we have to keep in mind that sometimes medication can also decrease the range of breathing.
I
But
would
the other,
also- oh, sorry.
I'm sorry, go ahead. No, you.
I would just also add that, this shortness of breath can also mean some other conditions that is basically, MS is not protective for other conditions as we get older, including cardiac issues.
So I had another question that is related to actually difficulty with urination. So it was frequency of urination, which is particularly difficult when taking an airplane. And the question was that there's a nose spray that person has heard about to prevent urination, to make the journey possible. So what you're referring to is probably a medication called DDA-VP or desmopressin, which we occasionally use to prevent urination for a few hours. But before we consider this medication, we usually use medication that have a direct effect on the bladder. This medication that you can take as a nose spray actually has an effect that is not an effect directly on the bladder. It's an effect on the water cycle in your body. And so it's basically using a much bigger hammer here, trying to accomplish something. So very often we'll think about medications such as Vesicare, Ditropin, or others before we consider the nose spray.
It's an anti-diuretic, so you have to be careful if you have high blood pressure.
And you can't use it on a regular basis, basically.
I have a question about progressive visual loss, and should I see a neuro-ophthalmologist, and Kaiser is not letting him or her see that person? Is there any advantage to seeing a neuro-opt? I guess it depends on what's going on. So rapidly progressive visual loss is uncommon in MS. If it's occurring over months or if it's in both eyes, you should definitely have your eyes checked, make sure you don't have another process such as glaucoma or compression of the optic nerves, which would require a special MRI of the eyeballs and the orbits. There are sometimes vitamin deficiencies, vitamin B12, copper deficiency, which can cause progressive optic nerve damage. So the advantage of seeing a neuro-ophthalmologist is that they may be a little bit more aware of some of these diseases. There's primary inflammatory diseases of the eye, like uveitis, that can be sometimes difficult to see if you're not looking for it specifically. So I think if you're losing vision quickly, that I would certainly see a neuro-ophthalmologist, just to get a second opinion from someone who might have more experience in the kinds of things that could cause that.